Nothing contained in this podcast should be considered a substitute for professional medical advice. This content does not represent our respective employers and is purely the opinion of the podcast hosts. We are not your personal medical providers. Sorry, friends. So, if you have any questions or concerns or are seeking advice, diagnosis, and or treatment, please seek individual, personalized advice from a healthcare provider in your area. We are not liable for any risks or issues associated with using or acting upon the information contained in this podcast. This is intended for educational and entertainment purposes only, so enjoy the ride. Welcome to Medical Media Mixer Podcast, The Perfect Cocktail. I'm Nicole Peniston. I'm a licensed clinical psychologist and certified brain injury specialist who has over a decade's experience working with children and adults, providing psychotherapy, psychological testing, and diagnosis. I have a particular interest in and experience with working with forensics, pediatric psychology, brain injury, and autism evaluation and treatment.
And I'm Tara Prisco. I'm a physician assistant who has been practicing in internal medicine and urgent care for over 20 years. I'm very passionate about women's health, autoimmune diseases, and preventative care. So, Nicole and I have been friends for 30 plus-ish years,
Now,
correct?
let's not age ourselves this early on. We've known each other for a very long time.
1993.
Stop with the years.
We met in high school.
Yeah.
We had some interesting adventures, and then we both sort of ended up pursuing careers that sort of circled back into similar interests. So we came up with this random podcast idea, and this is episode 1.
Welcome, guys.
So sort of what we're going to be doing is talking about medicine and media, tying it in with a cocktail, and we'll see where things go. My cocktail to start is called the Americano.
Ooh.
And the reason I picked this one is because it includes tonic, which includes quinine, which definitely plays a role in our episode. It's 1.5 ounces of Campari, 1.5 ounces of sweet vermouth, tonic water, basically just chilled and put up on top. If you wanted to make it a mocktail, I did look up. There's some Phony Negroni, or a brand called Ritual has an aperitif alternative that can be used for the Campari. And then the vermouth, there's actually a Free Spirits Vermouth Rosso, which is a non-alcoholic vermouth if you want sort of those herby flavors without the alcohol. All right.
Very
so
cool.
We're going to throw it back to close to when we met, actually.
Okay.
Dr. Quinn Medicine Woman. If we recall, did you watch this when you were a kid?
Of course.
Okay, so it's about a female doctor who moved from Boston to Colorado Springs after her father dies to find a place to practice medicine. It was aired on CBS on Saturday nights from 1993 to 1998. And total 150 episodes were made, plus 2 television movies that were made after the series was canceled. And the series basically starts in the year 1867, so it's very kind of Old West. It centers around a proper wealthy female physician from Boston, Michaela Quinn, played by Jane Seymour. Everyone called her Dr. Mike. So basically after the death of her father, she sets out to the small Wild West town of Colorado Springs to set up her practice. And she makes the difficult adjustment to life in Colorado with the aid of a rugged mountain man, and handsome as, of course, he is. He's a friend to the Cheyenne, Byron Sully, and a midwife named Charlotte Cooper, who becomes her friend. After Charlotte's bitten by a rattlesnake, Michaela is on her death. She asks Michaela on her deathbed to look after her 3 children. So she essentially adopts her 3 children, Matthew, Colleen, and Brian. She settles into town and adapts to her new life as a mother. And she's always fighting the uphill battle of convincing the townspeople that a female doctor can successfully practice medicine. So you'll see in this is back when the barber was your medicine guy.
Thank God we don't have that now.
Yeah, we're still bleeding people and craziness. So it's right around the time, though, where germ theory just started to become accepted. So it's actually an interesting crux in medicine where we're starting to understand that these little tiny microscopic critters basically that are causing our illnesses and how that works. And just like we've been through with the pandemic the past 4 years, it sort of mirrors that in trying to get correct information across to people and helping them to help themselves. So this is season 1, episode 2. So pretty much right out of the box. And the episode is entitled Epidemic. So basically how it starts out is Olive Davis and her cowhands return from a cattle drive in Old Mexico. They roll into town and they say, quote, "We've got a sick cowboy. He had a fever all the way since El Paso." And it cuts over to an ill-appearing gentleman. He's profusely sweating. And, Dr. Mike tries to intervene and help him, but they take him over to the barber shop to get treated because they don't trust her. Next up, we come to another scene where a woman's coming out of a church. Her baby is fussy. She's saying that her husband, Sam, couldn't get out of bed. Again, Dr. Mike says, "I can help you." But she says, "No, I don't need your help." We see Dr. Mike sort of scrambling to pick up some medications from the post office. In her mind, I think she's already preparing, knowing what this is that's coming. Later, of course, the woman with the baby appears at the barber shop saying the baby's burning up with fever. And Dr. Mike wants to pour cold water over the baby's head to cool her down. The barber's arguing, of course, because what does a woman know about medicine? And he wants to keep the baby warm to sweat the fever out. Now things get more serious. First person dies in town. And Dr. Mike says, "Hey, this is the grip," which is what they called influenza back then. Have you heard that term before? The grip?
I've not. What the heck is that?
So in Spanish, I learned it because Spanish-speaking patients call it gripe, Grippe. So when we talk about it with our patients via translation, the grippe or the vaccine for grippe. So that's the only reason I had heard of it called that. I didn't really get into what the actual history of the word is, but that's what they called it back in the day.
Cool.
So,
well, I have one question for you. You kind of alluded to it, but my first thought was, how are these townspeople taking to this new female doctor walking in like she knows everything? And you kind of answered it a little bit, but I don't know if there was more in that first episode or it really comes up second episode.
It really, when she rolls into town and they say Dr. Mike and then they realize it's Michaela, that right there, we thought it was a guy we were getting, right? But even then, they really relied on their barber as their medicine guy. I think it was the pastor is the one who hired her. That's who kind of runs the town. They didn't per se have a mayor. It was like the general store owner and the barber seemed to run things. But she did immediately get close with that Sully, who he's sort of an outlaw to begin with because he hangs out with the Native Americans, and Charlotte, who's a midwife, but also who runs like a boarding house with some women of the night, I guess, staying there. So she kind of made herself friends with sort of the outcasts to begin with and, built her little family from there. So yeah, I mean, they didn't accept her to begin with, but you'll see as the episode goes, some people may change their minds eventually.
Let's hope so.
So, of course, the children that she's now adopted, they want to help her take care of patients, but of course she understands that it's contagious, so she doesn't want them to come. You see scenes of people walking around the town, hunched over, weak appearing. They show another scene of someone actually being bled in the barbershop to, quote, "let the poison out."
Question about that, being bled, is that the same as when, like, back in the olden days, they use leeches, or is this a little bit different?
I mean, it's the same concept of get the poison out, definitely, but they actually did it by cutting you to make you bleed. Yeah. I mean, it is what it is. Or at least we're not talking about humors causing medical problems.
That's a little back in the day.
So, of course, now the baby's mother gets sick. Dr. Mike makes her rest. The postman now gets sick. And she tells him, "Well, I have this new medication, quinine. We got it in our shipment. Start to take this to get the fever down." And she comes to the pastor who runs the town and the barber and the general store owner. And she says, we got to do something. She tries to explain to them germ theory. We're in 1867. That was really just came about in 1860 by the French chemist Louis Pasteur. So, she tries to understand, the concept of these little teeny tiny microorganisms. And she proposes, let's make a makeshift hospital to basically quarantine people, which again, very much mirrors our experience over the past 4 years with understanding quarantine and what that means.
Yeah.
So they use the boarding house that her friend had previously owned and then was lost to the bank when she passed away. It's empty. So they, pull all the boards down and they come and they start putting the patients in there. During this, the youngest child that she has, Brian, comes down with the sickness as well. And the other children say, no, we're coming. We're going to help take care of the ill. We don't care if we get it. Somebody else in town dies and the pastor's praying over them. It sort of ends up being now a big emergency because the stagecoach refuses to come to town because they've heard about this town having this sickness. And so they can't get any supplies. So that becomes food, anything additional that they need outside from town. And they really get to the point where they're even trying to like break down the door of the general store to get supplies. It becomes mayhem as usual in humans.
And is that all because of the quarantine and the fear of contagion, or are there other factors?
So the stagecoach won't come because they heard about, the sickness in this town. I don't think they understand germ theory. They just think there's, bad air or something. I don't know. The stagecoach won't come. Mm-hmm. So, she is using the quinine. She's giving it to patients to get their fever down. But that supply starts to run low. Sully, the mountain man who works with the Cheyenne, he offers a tea that they use for fever that comes from purple cone flowers. At that time, she defers it. She said, I don't know what the proper dose is, what the side effects are. I don't want to give that to people without understanding it. But over time, people start to recover. And on the other end of that, they come back and they help take care of the sick patients. Then, of course, Dr. Mike herself starts getting exhausted. She's taking care of everybody. Eventually, the good old barber gets sick.
No.
And guess what? He comes and asks her for help.
How dare he? Send him away.
And she gives him some of her last drops of quinine.
What? Girl, you need that for yourself.
Right. Exactly. She basically divides it up between the other patients, doesn't save any for herself. Her little guy, Brian, he turns the corner, but eventually she basically passes out and she's in bed now, Dr. Mike. There's no quinine left. So Sully, the mountain man, says, screw this. I'm sending Matthew, which is her oldest son, quote, to go to cloud dancing, who's the Cheyenne medicine man, to get his remedy. So the medicine man, first, they have this fun scene where they take her bodily to a fire and they chant and they dance around her. And then they give her the special tea. So she's later in bed, and wakes up and sees the specialty at her bedside and, realizes, well, I guess the medicine man tea helped me in some way. Also, in the middle of all this, historical, General Custer shows up.
What?
Looking for quote unquote Indians. But
he actually called them that because I heard he used some other terms.
Right. But the townspeople actually cover for them because they recently just helped them with this medicine man tea. So they actually see the townspeople, they have a little arc too. They, come around.
Nice.
So influenza. What do we got about influenza?
Oh my goodness. It's like you knew what I was going to ask. What exactly is influenza?
So it's one of the most common infectious diseases. It's highly contagious and airborne, and it occurs in seasonal epidemics. So in the northern hemisphere, our season runs in the fall through the winter and ends in the spring. Whereas the southern hemisphere, it's in the opposite because their winter is during our summer. It's usually, there's 3 different types that we look at, influenza A, B, or C, and they're in a class of viruses called the orthomyxoviridae. And pardon pronunciation, I read these things in books. I don't actually say them out loud. So I think that's it. But, the most common way flu presents clinically is different than a regular cold in that usually you say the person looks like they've been hit by a truck. There's the severe, it comes out of nowhere. Like you can be fine in like 1 second, boom, fever, extreme fatigue, and extreme myalgias, muscle pain, sometimes a little frontal headache in your forehead, sometimes a little cough, sometimes a little red watery eyes. That's what sets it apart from the common cold for sure is the body ache, fever. Now, we used to be able to identify flu fairly easily because it was so different than all the other cold viruses. But now that COVID exists, it does become tricky because different years, different strains of COVID can present very similarly. So it's a little different, but we do have those rapid tests, which are similar to the COVID rapid tests that you remember, the little flow things with the swab. So we use those to help with flu diagnosis. The only thing is, just like COVID, they are highly specific. So which means, they are highly sensitive. hold on, my brain is not computing.
Sensitivity and specificity are two
Right.
different things.
Exactly. So basically, they're highly specific. So you get a positive is a positive. Like you don't get a false positive, but they are only moderately sensitive. So they do miss some cases. So a negative isn't 100% a negative. And that's same for the COVID testing. So a positive is hard cold, like you don't get a false positive, but a negative, if clinically it still kind of looks like it, we may treat based on what we believe is going on. A little bit about spread. So it's interesting. Do you remember during COVID when they talked about R naught, which is the reproductive number of a infection?
No, I don't remember about that.
So that's how
Fill me in.
How many people one person can infect?
Oh, yes. I remember that in the conspiracy theories of that.
I'm sure.
Yes.
So if I have seasonal flu, I infect 0.9 to 2.1 people. So 1 to 2 people, essentially. Back in 2009, there was the swine flu. That one was slightly different, 1.46 to 1.48. So 1.5 people. But just to give a little, half person.
Well, I have a question about that. Is that also affected by, like now compared into like the 1800s, we definitely have more access to vaccines and things like that. Do you think the contagion factor was higher or the spread factor was higher back then because people didn't already have these things floating through their system?
Yeah, I mean, that absolutely makes sense that your R naught was likely higher because you didn't have a percentage of the population that would be vaccinated. Just to give a little perspective back, which maybe will address this particular thing, measles, the R naught of measles is 12 to 18.
And that's at present, like currently?
Yes. So unvaccinated, like, right. You have to be susceptible, but one person on average can infect 12 to 18. That is insane to me.
Yeah, that's a lot of people.
So, I mean, our first, as we talked a little bit about, vaccines being always our first level of management is prevention, right? So, we do produce a new flu vaccine every year. Typically it's a trivalent, which has 3 different strains in it. And so for this season, it will be a trivalent vaccine. Some years there's a quadrivalent. I guess that just has to do with it. They study the previous year's most popular strains and that's how they get it. So this year it's trivalent. There's also a high dose one. I'm not sure if you've ever heard of that, which we give to patients over 65. Do you know why we do that?
I would assume, if I'm guessing, that the older you get, the lower your immunity goes.
Yes.
So you need to be protected more.
So, right. So you don't mount as a robust response. So they basically use 4 times the amount of antigen to get a better response because the older you are, you don't mount that antibody response as well. So yeah, that's exactly it.
And is it the same with babies? They're building up that immune response, or is it different?
Babies under, don't quote me because I don't take care of children, but I know that for sure at 6 months you can get a flu vaccine. And I think between 6 months and a certain age, you actually have to get 2 that first year.
Okay.
So the schedule and things change, but I believe children, they get 2 flu vaccines in that same season to boost them.
Makes sense. But in theory, babies are building up their immune response just as older people are losing their immune response.
Exactly, okay. Exactly. So there is also, I don't know if you heard little murmurings about the avian flu that's been around recently.
There's always some sort of thing going on. Tell me more.
Typically the avian flu comes from direct contact with birds, and now that's been some crossover into other farm animals. But in the past few weeks, there have been some cases that they are not able to trace back to contact with an infected bird. They can't prove person-to-person transmission, but it's something they're following very closely right now because that could be a whole nother unprecedented thing to have an avian flu going person to person. So for most up-to-date information, I would check the CDC and WHO, World Health Organization, because they're going to have the most up-to-date moment-to-moment as far as a good resource for that. It's something this season we got to keep our ears to the ground sort of and, be able to react if that happens. So who's eligible? We just kind of talked a little bit about that for the vaccine. Anyone age 6 months and older should get a vaccine. The uptake is very low, but we should. Usually you want to get it by the end of October because you want to make sure that you are immune before the season truly hits, certainly before holidays, because that's when we're all over each other spreading all the cooties. I definitely predict big COVID and flu surges as usual from Thanksgiving through New Year. So we'll see. And there, I don't know if you remember, did you ever hear of people who are allergic to eggs? They used to say not to use the flu vaccine.
I had heard it, but also I actually recently got my flu shot, and it was one of the questions on there.
Right.
So I assumed it has something to do with something that's in the vial of the flu
Right.
shot.
So they actually grow these viral cultures in egg proteins, basically.
Mm-hmm.
But last year's season, they removed that as a contraindication because the studies have shown that the likelihood of having an allergic reaction, even if you're allergic to eggs and get the flu shot, is pretty much nil. It's very, very low. It's not zero, but it's pretty low. So they've actually removed that as a barrier for patients who are allergic to eggs. So that was very new. So, I mean, we always tell everyone, get your flu shot, but again, the uptake is very low. And it kind of harkens back to similar with COVID. It might not 100% protect you from getting the flu. It might not, but it certainly can reduce your severity. So just for that, it's worth it because that's time off of work, time out of school, feeling crappy in bed, all those reasons.
Spreading it to other people.
Right. Yeah. Right. And that's where that quarantining that Dr. Quinn, she did the right thing. She made her little hospital and quarantined people. And actually, that was the next point I was going to talk about briefly, is that they've shown that by quarantining people, you can reduce symptomatic illness in the population from 12% to 4% by just using simple quarantining. More like hospitals, nursing homes, jail, congregate settings is where you can really use this. Temperature surveillance, things like that. Like during COVID, when I had to go into a nursing home or a facility, they take my temperature, do a rapid COVID test everywhere I went. Those actually work as same concept for the flu, and especially in those congregate populations, quarantining and doing these measures can help a lot. So treatment. Have you ever had the flu?
I don't believe I have. I feel like I had something flu-like right at the beginning of the COVID pandemic, but I don't know that it was the flu. It definitely wasn't COVID because I've never had COVID, believe it or not.
And you are a miracle.
It's the only good health thing I've got going for me.
Yeah. So the first time I actually had the flu was my first year out of school working in urgent care. And back then we didn't push flu vaccines in the same way we do now. It really was never pushed by my pediatrician growing up. It was not on our radar. I'm not sure if it was like a late 90s, early 2000s. We started really, I guess, recommending for everybody. So of course I worked urgent care, and of course I was around a lot of sick people, and we didn't mask back then. That wasn't a thing. So I got the flu, and it was literally, I was 24, 25 years old, and I could not get out of bed. Like I couldn't even reach my arm over to pick up the Tylenol bottle. It was horrible. I don't think I've ever, I think there was one other time when one of the kids got it. I prophylaxed myself. I took a prophylactic dose of a medication. So we'll go over the meds real quick. And that did prevent me from getting sick. So the meds we have available typically have to be started within 48 hours or else they're essentially ineffective. Sometimes they'll stretch that a little when a patient's admitted to the hospital. If you're sick enough to be admitted to the hospital, the risk benefit of giving you an antiviral, you might as well just give it so they can give it even outside that 48 hours. But, the two main ones that are on the market for outpatient would be Influenza, which came out in 2018 and didn't have a whole big uptake because I don't think, the 19 to 20 season for sure we had no flu because we had COVID. 18 I don't recall, but I think a new drug launched and you kind of didn't have a lot of uptake. The good thing about this one is it's literally a single pill, one pill, done, which is pretty awesome. You don't have to take something for 5 days. Yeah, it reduces your illness by 1.1 days in a healthy patient and 1.3 days in a high-risk patient. So that doesn't sound like a lot, but another 27 hours of being sick in reality, it would suck. So if it could reduce it by that, get you back to work, back to school, it's worth it. I mean, these aren't miracle drugs, but they are helpful. Tamiflu is the other one that you'll have heard of, I'm sure. That one came out in 1999. So that's been out quite a bit longer. It's a 5-day treatment, also has a prophylactic dose. So prophylactic is like you live with someone in your house who got flu. You can start this to prevent you from getting it. So the dosing is slightly different for the prophylaxis. And that does work. Tamiflu only reduces your illness by 0.7 of a day, so a little bit less effective. It does have a lot of GI side effects, so if you can't tolerate it and it's giving you a stomach problem, well, then it's not worth it. We use it. I mean, I offer it to everybody, but I think the new one, Sofluza, is definitely better. And then there were 2 other medications that I didn't even know existed that came across when I was researching this, which was interesting because I've been working in primary care and urgent care for all these years. One is an IV that came out in 2014, and it only reduces your illness by 21 hours. So less than a day. I don't even know where you get this, how do you order it, if I'd have to send them to an infusion center at the hospital. I know nothing about it, so there's that. It's called Rapivab Paramiravir. And then the other one is an inhaled medication called Relenza Zanamivir, which came out in 1999. It does reduce by 1.5 days, so technically it's actually the most effective, but you can't use it if you have underlying lung disease, which would be the people we'd really want to give something to. So if you have asthma, COPD, you can't use it. So, I don't know. I never heard of these other ones. They're probably expensive and hard to find in the pharmacy anyway. But they do recommend basically all high-risk patients be given an antiviral. And then at the clinician and patients sort of, discussion of risk versus benefit, you can offer it to patients who aren't high risk. So I offer it to most people. There aren't a whole lot of contraindications, so it's worth at least trying. So, I mean, that's kind of the treatment and the general idea of what is going on as far as the flu. As far as the impact, the World Health Organization estimates about 1 billion influenza cases each year, which is pretty crazy. And somewhere between 300 and 650,000 deaths due to worldwide. These are all estimates. The US in adults doesn't directly track cases. They just use statistical models. Not sure how the WHO gets their data. Now, but flu-related deaths in children is actually tracked. So that they do have actual numbers. They're looking at the numbers I had were pretty old, but 2019 to 2020, which is like the lowest season we had 486 children die. So I didn't have any other statistics recently to give per year.
Well, and what does that mean when it's flu-related deaths? Or are those more complications from the flu?
Right. So they call, flu-related, I guess the way they're wording that is they're wording it as, you're dying from complications of the flu, right? The infection itself isn't necessarily killing you, but you're getting a secondary pneumonia, dehydration, acute kidney disease, acute kidney failure from it. Something else
so
is
if
usually
you had
happening.
A cut, you're not dying from the cut, but you could die from an infection in the cut.
Right, essentially. And then when the whole tracking thing, and I think we learned a little more about this during COVID, is interesting because flu-like illnesses, I don't have a positive test in every single person, right? Mm-hmm. So we're not getting 100% this is flu. We're clinically diagnosing it. It could be another virus that's presenting very similarly. So that's why the numbers, I think, are a little bit hard to nail down. But for just a little numbers comparison, so we talked the Spanish flu, 1918, which we've talked about in the past with COVID. That was a big epidemiological. My brain isn't computing.
Epidemiological.
There you go. Comparison that we make. So the Spanish flu caused 500,000 to 700,000 deaths in the United States, which is insane, especially because the population was less then, and then 30 to 40 million deaths worldwide.
And was that more than COVID?
I don't have statistics in front of me, so I'm not going to speak to that. Interesting, and I brought this briefly up, the swine flu that happened in 2009 to 2010. Mm-hmm. That was interesting because the way that one affected was a little bit different. It affected people younger than 65 and higher pediatric mortality. And they think that was because people who were born before 1957 were exposed to other flu strains that were very similar to this H1N1 that was the swine flu. So it was the opposite. The elderly were actually fairly protected, which was interesting. And I worked through that season. I remember it being a little crazy. But in the end, the basic thing is patients with comorbid diseases are, of course, are going to be at the highest risk: diabetes, COPD, some of the biggest ones, age. And, get your flu shots and see your provider within the first 48 hours of illness if you want to try and get on some medication. So next thing is I want to just go quickly into quinine and also into that purple coneflower because those were interesting uses in this episode. So quinine has been used throughout history for quite a few different things. I couldn't find it being used for flu in particular in the 1860s, mostly just for fever. So that's what they were using it for. They weren't using it as an antimicrobial or antiviral. They were using it just to get the fever down.
Well, I use it now for muscle cramps.
So we'll talk about that because...
Well, I don't know if I'm using it. I'm drinking something that has it in it.
Right. I mean, what's in tonic and things like that is going to be a much lower amount than what's in an actual quinine pill. But originally, it came from the Quechua people in Peru. So they were using the ground bark of these cinchona trees, and they would use that into like a tea to help with rigors or shaking, typically from malaria. So, of course, the Spanish missionaries, the Jesuit missionaries had seen this, and they actually brought it over to Europe. So actually, one particular missionary, his name Agostino Salambrino, he sent some to Rome for testing as a malaria treatment. King Charles II was cured of malaria in the 17th century with quinine. So it became very, very popular, and it actually had a big impact on history. A couple different scientists through the 1700s and 1800s worked on isolating it, making it into pills. Back then, things weren't regulated, so, you can kind of make whatever pills. But it really started to be used for malaria prophylaxis heavily in the 1850s. And it marks the first known use of a chemical compound to treat an infectious disease. So this is like before antibiotics, before penicillin. We found something that, and which is interesting, we harken back to, the indigenous people using this and then it coming full circle. So it's interesting, how sometimes we poo-poo these things, but they were using it. Maybe they didn't understand why or how, but it was working. And so the other interesting play on history this had is actually because we had quinine, it played a role in the colonization of Africa because the white man couldn't colonize Africa because he kept dying from malaria. So now they all took quinine and didn't die from malaria. So as much as it had benefited history, obviously things happened as far as the colonization and slave trades and all these other things that probably happened more, because of quinine existing. Yeah. Is interesting. It also was used in World War II, and they were trying to block the supply when Allied powers were cut off from their supply of quinine because Japan controlled the Philippines and in Indonesia where they could grow these plants. That actually, they tried to use that as a way to hurt, I guess, the Allied powers, but it didn't really work out because Japan still lost thousands of troops also because they didn't use the quinine appropriately for themselves. So it didn't really change history much, but it was tried to be used as sort of like a biological way to, I guess, hurt the other side. So we talked about using it for leg cramps. So it was made for many years and was sold for leg cramps under the brand name Legatrin. And then Qvel. Those were made by major pharmaceutical companies. But in the 90s, so around 94, they pulled it off the over-the-counter as a treatment for nocturnal leg cramps because the risks outweighed the benefits for that particular thing. So they banned off-label use of quinine for leg cramps. Because malaria is life-threatening, the risks of quinine versus the benefit were considered to outweigh the risks. So that technically nobody can market anything with quinine and say that it is going to cure your leg cramps or anything else. Because the big thing, and so you remember hydroxychloroquine during COVID, hydroxychloroquine is a malaria drug that is also used for lupus and autoimmune diseases, but does carry a high risk of arrhythmias, and so does quinine. So they're related drugs. It's basically like an offshoot from that. So that's why risk benefit, well, right, we're going to cure you from malaria is one thing. Your leg cramps can whatever.
Yeah.
And the other, just one last thing that quinine was used for was it was a abortion method in various parts of the world,
Huh.
basically using it as an overdose to
Mm.
terminate a pregnancy, and also used as a cutting agent in street drugs, which I'm not really sure the benefit of that, but whatever.
I
I
just
don't
know that
really.
it's in tonic mixers and bitter lemon. And I've got it in
Right.
my house for if I have a leg cramp, I'm going to drink a little bit of that.
Yeah. I mean, obviously it worked at some point for that, but they just can't market it like that. And then the last thing just to touch on is the purple coneflower.
Yes.
So when the Cheyenne people were using that, what that was echinacea, which is what we know
Oh.
and have heard of. And so it's interesting because echinacea, kind of like anything, has its time where it's big, and then elderberry was big for a while, and there's different things that people, to use to prevent or to treat common colds. So it was used by Native Americans originally in the Great Plains, so that all historically matches. And there's thinking that it might stimulate your immune system to fight infection. Studies haven't shown it to cure illness, but they have some data on prevention of illness. It is, from what I can tell, fairly innocuous as far as low drug-to-drug interactions, low risk. There's just not robust evidence that it works. But it's one of those things that I'm not going to get upset if a patient tells me they're taking it. There's some supplements that I'm going to say, that might be dangerous. I'm not sure.
Yeah.
This one, there's really no bad data on it. They're saying short-term use is probably safe. Long-term use, they just don't have enough information on. So it's interesting. I mean, it's, again, going back to these native populations, finding something, using it, and getting some benefit without necessarily understanding the nitty-gritty physiology of why. So
Yeah.
that's Dr. Quinn Medicine Woman and the flu and quinine and echinacea.
Wow. I was hoping you were going to say the purple coneflower was ayahuasca. And I was like, tell me more. But no, that's something else. That's a natural medicine.
Right. Which, yeah, I know a little bit about that, but we'll have to look into that. Maybe that'll come up at some point. Wasn't there like a documentary with
Yes,
that
Kentucky
actor guy?
ayahuasca.
No, there was that actor guy too. What's his name? Who's the guy from High School Musical? He went to all different places and different things.
Zac Efron, yes.
Yes, and he did it. He did.
And Chelsea Handler has also done ayahuasca on her show. Yes.
Interesting. Yeah, I don't know. I'm like, the guy.
Yeah, the guy. And I knew exactly who you meant, so it worked.
All right. So what are we talking about for you today?
So for me, the cocktail, which the name of it is a spoiler alert, but the cocktail that I'm going to be suggesting for today is called the OCD. So spoiler alert, we're talking about OCD. But it is actually a proprietary cocktail made by a place called Orange County Distillery, which is in New York. They are I'm trying to find the town, sorry. They're in New Hampton, New York, and they make their own rums, bourbons, all kinds of spirits. And their house cocktail is called the OCD, which technically stands for Orange County Distillery. But it includes bourbon, their lemon rosemary simple syrup, which sounds delicious, and dark maple syrup. So simple, easy drink. Sounds kind of tasty. I'll have to see if I can eventually try one.
Yeah.
But the show that I'm going to be talking about today is Girls. It was a TV series originally on HBO. Now we know we can get it on streaming through HBO Max or any other of the streaming platforms. And Girls was I saw one place called it a cringe comedy, which I think is the best way to describe that show, because many of the moments throughout the seasons are very cringy, very awkward to watch. It was created by Lena Dunham, who is also the lead actress who plays Hannah. And this episode is going to be revolving around Hannah. Let's see. Sorry. I didn't have all that detailed information that you have. I know that it's 62 episodes were of Girls. It was 6 seasons, 62 episodes. And it premiered in 2012 and ended in 2017. So a little bit of a throwback, not quite as old as your show, though.
Yeah, I'd heard about it, and I know it was like critically acclaimed. I just never got around to watching it. There's so many things on my list of things to watch that I actually want to get to.
I will say I have a love-hate relationship with Girls. I think some of the episodes are amazing, especially it's actually 2 episodes that I'm talking about, but and then there's other episodes that are a little cringy. Definitely by season 6 or season 5, I remember liking the peripheral characters more than the main character, Hannah. She got kind of annoying, but I think that's also kind of part of the reason the show is about her. It's, dealing with those people in your life that aren't always so easy to get along with. I'm talking about season 2, episodes 8 and 9. I'm really focusing on episode 8, but there is some related content in episode 9 that's definitely worth a watch if you're going to watch it. So in this episode, episode 8, Hannah, played by Lena Dunham, who's also the writer and producer, is dating Adam, who's played by Adam Driver. And they have been dating for a little bit of a time, and Hannah's always had difficulty with relationships. And so she decides to break up. And the episode starts off with both of them in their respective solitude having a tough time. Adam starts to go to AA because he has an alcohol problem. And when he goes to his first AA meeting, he stands up and just starts talking about Hannah and how much he misses her and he wanted to be with her. And she was difficult to have a partner with, to be a partner of. So that's what's going on with Adam in this episode. But then Hannah's really struggling in this episode. She just broke up with Adam. She's an aspiring writer and she has a book deal, but she's under a lot of pressure to get chapters done, and she's falling behind and she's having trouble focusing and she's just feeling really overwhelmed. There's also a very, very, very peripheral reference to her having a urinary tract infection, which I think is relevant, but they kind of brush that off. But she does talk extensively in many of the seasons about how Hannah has anxiety. But then all of a sudden, by season 2, episode 8, which is approximately 19 episodes into this show, she suddenly has OCD. And so we find out actually so Hannah's stressing about her job, stressing about the breakup, stressing about life, and her parents come to visit. And as she's walking, the episode starts where she's just walking through the city from, I believe it's from work. I don't think they show where she's coming from, but she's walking from one place to her apartment, and you notice that she starts engaging in some odd behavior. And when you first see it, it almost seems like tick-like behavior. So for those who don't know, tics are repetitive, either vocal or motor movements that are not able to be controlled. But we soon quickly find out that Hannah is in control of this and she's choosing to do these repetitive movements.
So that distinguishes it from OCD. Okay.
That's one of the big distinctive differences. But for OCD, as the episode goes on, we learn a little bit more about what's going on. But she's counting to 8. So that's a big thing for Hannah, is having everything in 8s. So when we first see her turning to look back at someone as she walks past them, and then she has to do it 8 more times or 7 more times to make that 8 before she can move on. Then it slowly, gradually evolves over the episode to her looking side to side, like kind of shaking her head 8 times, opening and closing doors, turning lights off and on, eating or taking bites. So she has to eat 8 potato chips, but she also has to chew each potato chip 8 times before she can move on. And honestly, they make it seem a little bit ridiculous at first, but it is a very true depiction of what OCD is, where people get caught up in both obsessions and compulsions, which I'll get to in a minute. So that's kind of how we see the beginning of this. Then Hannah meets up with her parents, and her parents right away, almost within minutes of talking with her, notice that she has these compulsive behaviors coming back. And so they gradually try to broach the issue with Hannah that she should return to therapy. That's when we find out that Hannah had severe OCD when she was in high school. And so her parents noticed it. They feel like they worked really hard back then to help her get treatment, and she was doing really well for a while, but now that the stress is up, it's returning. Hannah is in complete denial that she's having any issues. She tells her parents that she's fine. She's denying these obsessions, which are repetitive thoughts, and she's trying to hide or ignore her compulsions, which are the behavior, but everybody sees them. In one scene, she goes to dinner theater with her parents, and she's feeling overwhelmed and anxious because her parents have just confronted her about this, and she gets up to leave and she accidentally bumps into someone, and then she has to go back and bump into him 7 more times. And so clearly we know that she is in denial of her symptoms if she's trying to get out of the situation and is still stuck in this compulsive loop. And so she also begins throughout the episode compulsive talking to herself. And so she has this actually very sweet little mantra that she does where she looks in the mirror and she says, "You are fine and you are good." But she has to say that now 8 times. So even though she's trying to probably use some skills that she's learned in therapy in the past. That positive self-talk is definitely a very therapeutic thing. It's not working. As we move further into the episode, now she's tapping and she's counting things, and it's just getting worse and worse and spiraling out of control until she finally agrees to go to therapy with her parents. They take her to the therapist office because they don't trust her to go on her own. And that's kind of where the episode is wrapping up. There's other characters in the show. None of their stuff really relates to OCD, right. So I didn't really pay too much attention about what's going on with them. But there's a really good scene at the end of that episode where Hannah is with the therapist, and he's basically saying, well, why are you here? What's going on? And she says that in high school, her OCD was very bad. That's when she was first diagnosed, and she was counting things in eights, thinking things in a loop of 8. And I wrote that down because I think that loop concept of doing things over and over is very consistent in people who are actually experiencing OCD. They feel like they're caught in a feedback loop. But she also mentioned some other symptoms that are actually not as unusual with OCD, but I think there are a lot of symptoms that people don't talk about. So one of them is doing these compulsions over and over, that then it starts to interfere with your sleep. And then the more tired you are, the more anxious you get because you have things to do the next day. And so it's kind of snowballing. She also said that she would count the pulses of her vagina, which sounds bizarre, but as women, you probably know exactly what that means right away. It's just a thing. It's just a muscle contraction, essentially.
Yeah. Doing her kegels. I mean, we're good.
Yeah. So she said that's one of the first things she was counting. And then I have a note here that she had to force herself to see things on a loop of 8, which she didn't really explain in the episode. But what I think that's more of the obsessions, where now you're searching out things in 8s. If it's part of your thing that you can't stop, now you're trying to find that everywhere. And so she's looking for 8s in order to make her feel not anxious.
Interesting.
She's also has intrusive thoughts that are bothering her. That's why they're intrusive. About sex and murder, which those type of things are also very common in people who have anxious thinking, to have intrusive thoughts of being killed, of killing someone else, of being raped, of raping someone else. Those are very common intrusive thoughts with some people. And then she also said that when she's caught in this loop of 8, she had to masturbate either 8 times or in multiples of 8. Which would then result in actual physical pain from doing that so often, and crying and shaking. She'd have to check the door. She'd have to brush her teeth. She alludes to at one point having to brush her, I'm not sure if it was brush her teeth or move her toothbrush 64 times because she was so caught in this 8 multiples. And then she talks very briefly about how she didn't want to go back on medication because it made her fatigued, which we'll talk about meds in a little while. And that the episode ends essentially with her asking the psychiatrist, she's not actually with a therapist, we find that later, asking the psychiatrist to tell her parents that she's okay, and to not tell them that she does not want to go back on medication, which I think is very common in people who have mental health issues, and sometimes medication feels like a weakness, and so they don't want to resort to that. Other things that come up in this episode with Hannah is some of her other very complicated mental health issues. She has a lot of emotional distress, both when she's happy about something and both when she's sad about something. She's very kind of all over the place, but the only diagnosis that they ever talk about in this show is OCD. And unfortunately, even though they really do a very beautiful way of describing what it's like for someone to have it, it's only ever mentioned in these two episodes, episode 8 and 9. And then
so just magically it's gone.
The entire rest of the season, it's never mentioned again. Now, I haven't rewatched all 6 seasons recently, so maybe there's more subtle presentations of it, but they really only focus on it for those 2 seasons. Now, there is kind of like an after the episode with Lena Dunham, and she talks about how she had her own experience with OCD. And so she was really trying to make people feel seen and heard that it's something. But the sense that I get, she doesn't say this herself, but the sense that I get is that maybe it was a very personal experience, and so she didn't want to make the whole show just about that. I think that's all that happens in that episode. So So that's episode 8. In episode 9, there's a really remarkable scene where, again, she's still struggling with doing things in this loop of 8, and she is cleaning her ears with a Q-tip, and she's done it multiples of 8. I don't even think we're counting at that point. And she does it so much that she actually injures herself and has to go to the emergency room. So which I think that, it doesn't happen as often with people with OCD, but it can, depending on what your compulsion is. It can cause self-injury, which, I feel like in the field, we don't necessarily call it true self-injury because the intent in that action is not to injure yourself, but it has resulted in injury. So let's talk about what OCD is. So
Sure.
OCD stands for obsessive-compulsive disorder. And as I've alluded to, it includes uncontrollable and recurring thoughts, which we call obsessions, and repetitive behaviors, which are compulsions. You can have OCD and only have one or the other, but a lot of people, the two are connected. You have this repetitive, recurring, uncontrollable thought that causes you distress. And then so some people sometimes link that thought to, if I do this behavior, I'll feel better. But it can be very time consuming, as I alluded to before. People can lose sleep, you can miss work, you can, forget deadlines because you get caught up in this very anxious, unwanted loop of having to do things repetitively, or not being able to shake those repetitive thoughts. So some very common obsessions with OCD are fears of contamination. That can go off the rails really easily. I once worked with someone who, I'm not 100% sure if he had OCD. He definitely was presenting with very similar features, but his contamination fears led him to stop eating completely because he was convinced that someone would be poisoning his food. And so he would not eat. And it was actually very heartwarming. I saw him within the setting of a group, and other group members would try to bring him food or take him to find food of his choice and pay for it to get him to eat, but he still was refusing to eat.
So what would separate that from just being a delusion associated with schizophrenia or schizoaffective disorder?
So a delusion itself is a thought that is clearly patently untrue to everyone. It's not reality-based at all, where with obsessions can have somewhat of a basis in reality. It's just they then spin out of control.
Got it.
So it's really the reality checking with that's the difference. Or honestly, the ability to check reality. You can have a delusion that's super bizarre and not realize that it's bizarre, but you could also have an obsession that's super bizarre, but that it's unreasonable, and that's
Okay.
really where that anxious distress comes from with OCD, is that there's a part of you that knows that this is not good, this doesn't feel good, but you just don't have the ability to stop yourself to control that impulse. So I said some of the common, lost my screen, there we go. Fear of contamination or germs is a big one. Fear of forgetting, losing, or misplacing something. So this one gets tricky because honestly, when you just say it like that, it feels a little bit like hoarding. But this is a different quality of it. It's not, I need all of these things because I don't want to lose them. It's more of, I forget my keys. So I have to have 7 sets of keys because I'm going to forget my keys, even though you may still have all 7 sets with you. Fear of losing control over one's behavior, that's just a very common anxiety symptom. OCD is a type of anxiety disorder. But that fear of losing control over one's behavior. So you're having these thoughts over and over again, but now you have a fear that you're going to act out those thoughts, especially if they're those obsessions that I said, like are sexual or violent in nature. Other taboo thoughts involving sex or religion or harm to others are, like I said, a key concept of what those obsessions can be. And they're really just thoughts. The majority of people tend not to act on those thoughts, but they're almost afraid that they will act on those thoughts. So it's almost wanting to go through with the compulsion, the behavior, but knowing that it's not appropriate. So holding yourself back, but then because you're holding yourself back, the thought almost gets stronger. Does that make sense?
Yeah, it's interesting though, because it really sounds sometimes like the overlap with forms of psychosis, and it's hard to piece out, will they go that far or not? So if someone's in an acute setting, differentiating between the two is important, obviously.
Yeah, I think the difference with just psychosis in general is the reality base, the ability to check in, things like that. A lot of times people are psychotic, but they're not distressed. It's just what they're saying and doing is bizarre and psychotic in nature. And so it really is a difficult differential, especially if you're just meeting someone or meeting someone very briefly.
Right.
It takes a lot of work to kind of dig deep and find out the difference between the two.
Got it.
And then the the most common obsession that most people are familiar with OCD is to have things symmetrical or in a perfect order. So your house has to be 100% clean. You know, all the lights have to be off, or all the lights have to be on. There needs to be some sort of symmetry because that feels comfortable. And that is a very common kind of overlap with sometimes things that we see in people who have autism, with like lining things up and stuff like that, where there is an anxious part of it, but also a lot of those people, it's just automatic. There's not necessarily anxiety involved with needing to line it up. It's anxiety with when it's not lined up. If that makes difference.
Okay.
So like with
And
obsessions, it's the anxiety to line it up. But with
Okay.
autism, it's the anxiety to not have it lined up.
And that's where you see like children just do things, or I think as children, some of these things you do yourself, but where does it end up that it crosses the line? I guess is the distress where it crosses the line.
It's the distress level and the functionality of it. So a lot of times people with OCD can make their obsessions and compulsions functional. So if someone is going to be a writer and they are obsessed with perfection, they're going to reread their manuscript 60 times. So they can make it functional. Whereas with autism, a lot of times it's going to interfere with your social ability. It's going to interfere with social interactions, where a lot of people with OCD, usually, not all the time, have a way of making it socially acceptable or hiding it enough that other people don't see. I also think there's like an awareness with OCD. People are still aware that, okay, I'm having this thought over and over again and it's probably not good. Whereas with autism, I think it's more of a way you're seeing the world. You're seeing a world in a way that needs to be symmetrical versus feeling like, I don't know, am I making sense? I feel like I'm spitballing a lot right now.
It's just funny because you can see in your own self, like in your lifetime when you've done things like that. Like who as a kid didn't say, I have to jump over all the cracks and I can't step on one, or I have to do this and hop on this. Like as a child, I could see that. Like I don't do those things now, but I definitely did things like that as a kid.
Well, and I'm glad you brought that up, because that's the difference between what a superstition would be and an obsession. A superstition is something that we've heard socially, we've gotten from other people. We didn't make it up in our own heads, where an obsession is something that only really the person who has the obsession understands the true meaning and gravity of.
Okay. Yeah. I mean, it's just so hard because I think it is all a spectrum, right? So like there's no behavior that's normal stone cold and abnormal stone cold, right? There's definitely a spectrum where there's a line that gets crossed where it becomes more of a dysfunction.
Yeah.
Right. I mean, it's interesting.
And then compulsions, like I was saying, are repetitive behaviors. So a lot of times they're connected. The behavior is in response to one of those compulsions. So that would be excessive cleaning or hand washing. Those are the ones we see about most in the media. Ordering or arranging things in a precise or particular way. Repeatedly checking things. So checking that the oven's off, checking that the door is locked. Compulsive counting. This one is probably one of the more difficult compulsions to identify, because we can be counting things all the time and no one would know if you're counting them in your head. Right. So sometimes it's not necessarily an outward behavior, but it's still something that you're doing with purpose. And then praying or repeating words silently is another compulsion that can be very common. And kind of like we already alluded to, the difference is the inability to control those obsessions and compulsions, even if you know that they're excessive. And that understanding of something being excessive or problematic, it varies per person. A lot of times there's a lot of denial in OCD until it starts to interfere with social functioning or your job or productivity, things like that. The hallmark, and I think this is hard because a lot of us are not really good time tellers, but spending more than 1 hour a day on those obsessions or compulsions, I think it's really hard to track that, especially if it's a thought, because you could have the thought for 5 minutes now, but are you really counting, is it exactly 5 minutes, or does it feel like it was 5 minutes? Or have I been having this thought all day, or has it really just felt all day because it's so distressing? So that time piece is sometimes hard to track. And then this is another part of it, is these people are not getting pleasure from that obsession or the compulsion. It's more to reduce anxiety. So it's to reduce distress, but it's not fun. And I think that comes up a little when we were just talking before about autism. Sometimes people who have autism, they get joy from lining up. Like that is play for those kids who line things up. That feels fun. They enjoy doing that, where there's no pleasure from the compulsions. And then the compulsions or the obsessions, they're going to cause significant problems in your daily life, which is really the hallmark of anything that is considered a disorder. It has to cause some sort of interruption in your day-to-day life. So that's OCD. So not to be confused with obsessive-compulsive personality.
I was going to say that because I've had to study the personality disorders, and I'll have to restudy them for my boards again in the next year. But I know there's a difference, but in my brain, I don't remember the difference right now.
So personality disorders in the field of psychology, it's a big debate because I think in the old DSM, in the DSM-4, the difference between personality disorders and everything else in the DSM, which is the Diagnostic and Statistical Manual of Mental Disorders, for those who don't know. It's the big book of psych problems, that I like to call it. But in the former version of the DSM, personality disorders had their own section, and what differentiated them from other things is that these problems that the personality disorders cause are not problematic to the individual who has them. They're problematic to their social functioning.
Right.
And that made it really difficult for us working in the field because those people don't want treatment.
Right.
Or they're being asked to enter treatment by family or friends or bosses, things like that. And so that can make it really difficult to change something that somebody doesn't think is a problem. That's not to say that everyone who has a personality disorder doesn't feel it's problematic, but the symptoms are not causing distress. And so that's the difference between not causing distress in the individual necessarily. They may realize that it's causing problems, but day to day, they're not experiencing anxiety or depression or unrest due to those symptoms.
But are other disorders comorbid often with these, in that somebody who has a personality disorder, are they more likely to also experience another mental health diagnosis?
They can. And so that was why I was talking about the old DSM, because in the new DSM, they kind of shifted personality disorders and they're in a different area. And the feeling that I get, and that I think a lot of people in the field get, is that they're trying to phase those out and maybe have a different label for them, or maybe subsume them in a spectrum of other disorders. So OCPD, obsessive-compulsive personality disorder, may eventually get looped in on a spectrum of OCD-type disorders or repetitive anxiety-type disorders. But as of right now, they haven't made those decisions because I think there's enough people in the population who are struggling with it that we still want to make it notable without just saying, oh, it's not a problem at all. And that really is the point of the DSM is, in theory, if you read, from cover to cover, it's not supposed to be in there unless only a certain percentage of the population has it. We do know that more and more people are being diagnosed with things like ADHD or autism or things like that, but yet they're still in the DSM. So there's some work that needs to be done on differentiating what is a disorder versus what is just something that is happening socially to people as we evolve, as the world changes.
Interesting.
So with OCPD, obsessive compulsive personality disorder, the difference is that it's more of a preoccupation with order, perfectionism, control. So those things of wanting things to be a very specific way, but it's not necessarily having repetitive behaviors with it. It's more of a preference for things to be a certain way. So lack of flexibility, it says lack of generosity. I don't know exactly what they mean by that as a specific criteria, because some people are not generous because they can't afford it. There's other factors to it. Right. But it can definitely cause anxiety or frustration in the person who has it. They're very rigid with their routines. So this is the type of person who goes to the same coffee shop every morning and gets the same drink because that's what they like. But if that coffee shop is closed, they're going to be able to move on with their life and be okay. So that's the difference. They want that repetitiveness, those things a very specific, structured, rigid way. But if they can't do it, they're able to move on with that hallmark distress.
Understood.
In general, though, they may be more of a generally anxious person. And so having things that certain way helps manage that general anxiety, but it's not anxiety regarding, I have to do this behavior because I have this specific thought. Does that make sense?
Yes, definitely.
And that's really the main differential. I mean, personality disorders, like I said, it's a whole separate animal in and of itself. And maybe in the future, we can talk about personality disorders a little bit more. But there is that difference of the anxiety and the fear and the disabling nature of the symptoms versus being able to use those symptoms in a more positive way or a more functional way. And so that's OCD, that's what it is. Are there risk factors for it? So we don't know exactly, but there are definitely some things that may increase chances of developing the disorder. So studies have shown that if you have a first degree relative, so that's a parent or a sibling who has OCD, there's an increased chance of developing the disorder. But of course, as we know, that whole nature versus nurture debate, are you just doing it because you've lived with people who've done it your whole life?
Exactly.
There's a difference.
That's so tricky especially because of the way that particular thing functions. It's something you're going to see.
You're watching, yes, exactly.
So that's interesting, nature versus nurture. That's a tricky one.
Yeah. And scientists haven't identified any specific gene or set of genes or gene defect. So as of right now, we know that there's that likelihood, but we're not quite sure why. Biologically, people who have OCD, their frontal cortex and their subcortical structures tend to react differently to different things. And so those areas of the brain, the neural networks, things like that, when someone has increased anxiety or fear or obsessive thoughts or compulsive behaviors, they're kind of firing a little bit differently than other people's are in set clinical settings, when we're doing trials and things like that. But again, they're still working on trying to figure out exactly what part of the brain is causing what to happen at what point and why, and how do we manage that. Temperament. Sometimes kids who are more reserved or more kind of traditionally depressed may develop more anxious and depressive symptoms as a child, and those may develop into OCD-like tendencies. And then also childhood trauma, which I think that really taps into that kind of obsessive need to be controlling things. If your life has been all over the place and chaotic and you're a child and you have no power, maybe a way to manage that is trying to do these things that make you feel good, at least in theory. No one's actually sitting there and saying, my life is terrible, I'm going to do this and it's going to make it better. It's just more of adaptation to the hectic environment.
Is there an average onset of age or diagnosis?
So for personality disorders, they're not going to be diagnosed until adulthood. So we would need like a longer amount of time. But for OCD specifically, it can be diagnosed in children. But the big blue book, the symptoms, usually children have to have less of those symptoms for a longer amount of time. And adults need to have more of the symptoms for a shorter amount of time, if that makes any sense. And then also, this was interesting. I didn't know this until I just clicked on this link that was telling me more about like the genetics and the stuff about OCD. Apparently it's also comorbid with pandas, and that's a whole different thing that we could get in on another day.
But yeah,
but also autism is highly associated with pandas as well. So there's a whole, and pandas for people, it's pediatric autoimmune neuropsychiatric disorders associated with streptococcal infections.
Yep.
So after you have a strep infection or after you have strep throat or things like that, a very small amount of people are developing these neurological disorders after, and it's being associated with that. There's still a lot of work to be done on pandas, though, so we'll just put that on a shelf for another day.
Right. Every time we speak, I come up with more things that we need to cover in my... I
know when you were talking, I was like, we need to do this and we need to do this. I didn't write any of them down, so I'll forget them. But and then how are we treating OCD? So typically, one of the first line treatments is psychotherapy, because as nice as it is to take a pill and feel better, a pill is not going to change your thoughts. And we do know that with OCD, it's heavily related to your thoughts. So one of the first line treatments for that would be cognitive behavioral therapy, CBT, which is helping people to recognize their harmful or untrue ways of thinking. So that way they can then change their behavior in response to that thinking. That's really just the very basics of what CBT is. But that can be very helpful with someone who's ready and willing to change those thoughts. So that's the other thing with those obsessive compulsive thoughts and behaviors. Sometimes people don't want to change them. They may know that, hey, this is bizarre that I'm doing this, but they're like, well, it's not affecting my life. I don't want to do it. Very similar to Hannah in this episode of Girls. She feels like she's doing fine and she thinks she can meet her book deadline and she can, find a new boyfriend or find a new relationship and do these things. And these behaviors and thoughts are not getting in the way. Whereas someone on the outside is like, girl, what are you doing? Like, why did you turn around 8 times just now? Like, she's not seeing the difficulty that it's causing her. Not yet anyway. She will in the next episode when she has to go to the ER. Another type of therapy that works pretty well for OCD is exposure and response prevention therapy. So a lot of people have probably heard about exposure therapy. So that's when someone has a fear of something. So like in this, so let's say a contamination fear, so fear of touching dirty dishes. You're gradually working up to help someone touch a dirty dish and not wash their hands after, because the hand washing would be the compulsive behavior that happens after that obsession about dirty things. Exposure therapy, it takes a very long time and it's a long process, but the goal is to help someone face what that anxiety is and help them see that, hey, I did that and I didn't have to wash my hands and nothing terrible happens. The problem is because it can be so anxiety provoking working towards those things that are bothering you, a lot of people drop out of treatment. So even though exposure therapy can work really well, it's really hard to maintain someone, especially because it's a long road. You know, you start off by literally just saying, what are these things you're afraid of? Okay, let's make a list. Let's make a fear hierarchy, a list of how the things that you're afraid of from the least scary to the most scary. Sometimes even just that practice can cause people to want to leave therapy because they have to, be honest, they have to talk about these things that are really scary to them. So even though it's an effective therapy, it can be really hard for people to go through with that. And then also, we were just talking about children with OCD. Sometimes they need help from their parents or their siblings or, their social support network to put these things in place to prevent the behaviors, to help manage the thoughts. And if the family structure doesn't have the time or the effort or the understanding to help kids, a lot of times children are not really able to do it on their own. And so I think that's with any child in therapy, they really need that the parental or the social support to work through these things. And if the parents are just unable, not even unwilling, if they just don't have the mental energy themselves or the time to do it, it can be really difficult to manage in children. And then that's why we do say that OCD is lifelong, because it tends to, once it starts, you kind of always have it. It's just kind of having flare-ups here and there. People can have OCD and do well without it, but then if they're under a severe amount of stress, like Hannah is in this episode, then those symptoms can come back. So at least that part of it was very realistic as far as how she had it in the past. She didn't have it for a while and now it's back. That can definitely
So the stressors, stressors pushing you over the edge.
Yeah. And I mean, some of these stressors, you can't help it if, you just got the job of your dreams and there's a deadline. Like that's what work is. Right. That's what life is. You can't help it if you break up with your boyfriend because it was a dumb decision. Yeah. Spoiler alert, they get back together. So, and then there's also medications that you can take for OCD, but those medications typically are addressing either the anxiety that is associated with it or the depression. There is a chemical transmitter in the brain that is linked to both depression and OCD. So, antidepressants, specifically SSRIs, are usually the frontline. SSRIs, a selective serotonin reuptake inhibitor. Those do have a lot of side effects and medication interactions, though. So a lot of people aren't always loving to go on SSRIs, but they can be very effective.
So I have a lot of experience because in primary care, that's kind of our bread and butter is SSRI first line, because it's way safer than the older things like the MAOIs and the tricyclics and such. And, newer generations are a little bit cleaner. So I actually had a patient a few weeks ago come to me saying he thought he had OCD. And, I manage a lot of anxiety and depression, in primary care because we're kind of the first line where they start, but that's not something I have specific experience in diagnosing. So I was able to find, I did both a generalized anxiety questionnaire as well as an OCD questionnaire and scored him out. And basically for me, the treatment is going to be the same regardless.
Yes.
One of those SSRIs that is specifically has the indication for OCD is the one I chose. And then I explained that, obviously therapy is a mainstay, but I can't always bring them, hold their hand and get them there, but I have them here. So I feel like starting at least the pharmacologic management, if it can take things down a little bit so they can manage it better, is better than nothing, because the problem is some patients then don't go make that therapy appointment. So.
Right. Or some people fill the prescription and then take it for 2 or 3 days and then they don't like the way it feels or feel like it's not working and then they discontinue it. So that's why where medication is tricky is somebody needs to actually take it for it to work. And a lot of people have mixed feelings about medications, especially psychiatric medications.
So again, in primary care, I have this conversation day in and day out. And I feel like the past week or so has been an anxiety depression week for patients. I'm not sure if it's the time change, but patients are coming in.
It's the time change. It's the holidays. It's the election. It's everything.
Yeah. And so, but I have the same spiel that I say to everybody. I'm like, if it's your blood pressure, I'm going to treat it. It's a medical problem. If it's diabetes, I'm going to treat it. This is a medical problem.
Mm-hmm.
You have to take away the guilt. You have to take away the stigma. There's genetics, there's trauma, there's a lot of things involved in this, but like, there's no shame in treating a medical illness, and psychiatric illnesses are medical illnesses. So I try and really reinforce that with my patients. I also try and give them really good expectations on the medications.
Yes.
I explain to them, SSRIs in particular, first 2 to 3 days, you are likely to feel jittery, dry mouth, and nausea. I explain to patients, I have the same spiel every time. This is not a reaction to the medication. Your body's been deficient in serotonin for all this time, and now it's out and circulating, and your body's a little bit not used to that. Yeah. I also say 4 weeks. We are not even looking for any improvement, significant improvement. 4 weeks. You may have a baby bit of improvement. 4 weeks is where we're going to touch back, see where we are, and decide what the next option is.
Yeah.
So you have, like, as a provider, you have to give them those expectations and explain it and take that extra 2-3 minutes to do it. It's going to be more successful for the patient in the long run, and they're going to be more likely to be compliant. I also tell them the first 2 or 3 possible side effects. It may make you sleepy, may make you not sleepy. Some people take it in the morning, some people take it in the evening. Figure out who you are. Some people gain weight, some people lose weight, some people are weight neutral. Decreased libido and sexual side effects.
I was just going to say that. That's a big one.
That's a big one. Some of the newer ones, I don't know. I'd have to look up if they have an OCD indication, but they definitely have a depression indication, anxiety. Yeah. Some of the newer ones do say that they are a little better for the libido, but I don't know if they have that specific indication.
Yeah. So I was just going to say, some of the tricyclic antidepressants are slightly more effective than the SSRIs, but sometimes those side effects are even more. So then it's really kind of what is someone willing to sit with for a couple of weeks to see if it improves their mood and the behavior. And then also, if someone really has really difficulty with insight into their illness or is really struggling with other mental health issues as well, they could also go for some of the stronger drugs like Risperdal or Abilify, but those are not specific to OCD. It's more just a general antidepressant or mood stabilizer that could be helpful if other things aren't working.
Right. We use those as add-ons to resistant depression.
Add-on to everything.
Oh, but there's some newer, cleaner ones, honestly, that I'm using more and more, and I'm seeing really good success with, like Rexulti and Vraylar. I mean, I'm seeing really and a lot less side effect profile than the other, antipsychotic / add-on for resistant depression meds. So less metabolic stuff too, because diabetes and triglycerides going up. And I mean, at the time, that's what we had. But the newer, cleaner stuff is always,
Yeah, and you make a good point too. Like, no one lives in a bubble. So you've got, you might have OCD, but you may also have like 6 other things going on. And so you have to find the medication that's not going to exacerbate those other things. Because if now you're not feeling well or you're having difficulty in other reasons, that's not going to help your anxiety to manage or your depression to manage your OCD. There's also some treatment. This is not used very commonly, but it can be effective. So deep brain stimulation. That's rarely used in OCD, but that's really for someone who has intractable OCD. They've tried all the medications on the market. It's not working, or they're getting worse. And just, a quick cover of deep brain stimulation. It's used for many neurological disorders or neuropsychiatric disorders. But basically what they're doing is they're implanting very tiny electrodes deep into the brain that will stimulate certain regions of the brain that would help reduce those symptoms. It's kind of similar to how people may have deep brain stimulation for Parkinson's or for seizure disorders or things like that, where you're basically choosing to have a tiny computer put in your brain to help manage those areas that are kind of firing out of control and doing things out of control. Some people, it does sound very sci-fi, but it can be very effective. The effectiveness with OCD specifically, it's used so rarely that I don't know if we have the studies that are showing like long-term effects, but with those other disorders, it can be very helpful.
And like access to finding something like that too.
Yeah. You would probably start with a neurologist, but even then, I think the neurologist is going to want to make sure that you have tried therapy already, that you've tried antidepressants, probably tried some antipsychotics if you had to. They'd really want that to be the last line of defense to treat OCD, because it is brain surgery essentially, and the risks that are inherent with that. And then, so the prognosis, like I said before, OCD is a lifelong disorder. It can come and go in its severity, but it's not something that, you take this pill and it's gone forever. It is going to be something that may come and go throughout the lifetime. And when that does happen, it tends to be based mostly on those environmental stressors and how well you're managing it. Another thing I think people don't realize about any mental health disorder is if your physical health is out of whack, your mental disorders are going to rear their ugly head, unfortunately. When it rains, it pours. So if you're having some physical illnesses or other things going on, you're more likely to have an exacerbation of your mental health problems, just because there is that mind-body connection that a lot of people don't necessarily believe in, but it is factual.
So this goes the UTI that you mentioned.
I was just going to say that. So I'm sure, as you know, because I feel like it's the first thing they teach both you guys and me first day of class, is if there's a UTI, check for everything else, because those are going to cause all kinds of issues. So when they kind of blow off that Hannah has a UTI, for me, working in the field, I was like, why are we not checking this right away? And they never talk about her UTI again. So I don't know if it resolved, what's going on with all of that. I feel like it was kind of a throwaway comment for people like me who are watching the show and are like, what else should I be looking for? But a urinary tract infection can cause many, many symptoms, and some of them can be psychiatric in nature. So that's always something to look out for when, like I said, talking about that mind-body connection. If your body's off, your brain might be off. If your brain is off, your body might be off. They are connected. And on the other side, when we're treating our bodies well, our mental health is going to improve. It is factual. When you're getting enough sleep, when you have a good diet, when you have exercise, your mental health is going to be better. Even if you've got something severe, those symptoms are going to get better once you take care of your health. So that's what I've got. Did I hit everything? I think I did.
I think so. I think we did it.
We did it. That was pretty cool.
First episode success.
I know. I'm so proud of us.
So if anyone one day is listening to this, please come back and listen to us again. This is Medical Media Mixer. We actually have an Instagram page that hopefully will have something on it by the time we launch this episode.
It will.
At Medical Media Mixer. And we have an email account where you can send us ideas for episodes or commentary, medicalmediamixer@gmail.com. I would put the subject of what you're sending in the subject area, the topic of what you're saying, so that we can maybe, like, once one day we have so many emails, we can sort through by subjects if we want to give someone credit for suggesting in an episode.
Yes. And feel free to just shoot us an email and tell us that you loved our podcast, because I know you did.
Oh, and definitely, absolutely review us, subscribe.
Rate, review, and subscribe.
Follow all these potential people that don't exist yet that we're talking to.
They all exist, and they love us.
So thank you for listening. Medical Media Mixer, the perfect cocktail.